Okay, it looks like it's top of the hour. Happy holidays to everyone, and thank you for joining us for the webinar today. Just a couple quick things before I pass it over to Nania to introduce our speakers. For the questions that you have throughout the webinar, feel free to submit those in the chat function, and we'll try to get to those at the end. And for the U.S. attendees, certificates will be available this Friday by logging into your account. Nania, if you'd like to introduce our speakers, go right ahead.
Thank you, Kim. Welcome, everyone. My name is Nania Scherer Hernandez, and I'm the Director of Global Education here at Medela headquarters in Switzerland. Thanks very much for joining us today. This is the 8th installment of our webinar series on COVID and breastfeeding, so we're really excited about that. It's a very nice way to end the year of webinars for us in any case. Welcome back if you have already been with us for the past webinars, and thanks for keep coming back. We are all witnessing how the COVID-19 crisis, which has changed the way we work and the way we function, is also a crisis of resources at the hospital level. And of course, to manage this crisis at the hospital level, different measures have had to be taken. And at Medela, we want to understand the impact that these changes are having on breastfeeding and lactation. Since the hospital is a place in which many mums give birth and initiate breastfeeding. We are really fortunate to have Dr. Dani Dumitriu, a pediatrician and neuroscientist, and Dr. Cynthia Jamfi-Bannerman, an obstetrician gynecologist specialized in maternal fetal medicine, with us today. They work in New York, which, as you all know, was an epicenter of the COVID-19 pandemic early on. The two of them were on the COVID front lines and have personally cared for one of the greatest populations of SARS-CoV-2 laboring mothers and their newborns at a time when very little was known about vertical and perinatal transmission, very little was known about the best practices for this vulnerable population, and very little was known about long-term consequences on the mother-child dyad. We need to remember that early on, multiple organizations had released interim guidance for the management of pregnant women with SARS-CoV-2 infection and their newborns. But at that time, given the absence of data on the rates of vertical and perinatal transmission, the recommended practices were conservative. And these recommended practices included mother-infant separation and no direct breastfeeding. So in this webinar, Dr. Dumitriu and Dr. Jamfi-Bannerman will discuss their experience that includes this rapid mobilization they had to have to generate one of the first large data sets on vertical transmission. They will also show some of their ongoing work on the COVID-19 mother-baby outcome study, which is a large multidisciplinary initiative that follows exposed mother-baby diet. So this is really, really cool longitudinal study. And they will discuss perinatal practices as well. So before I hand over to Dr. Dumitriu and Dr. Jamfi-Bannerman, please let me remind you to feel free to pop your questions into the chat, as Kim mentioned before. We should have time to address them at the end of the talk. And please welcome Dr. Dani Dumitriu and Dr. Cynthia Jamfi-Bannerman.
Thank you. Thank you so much for the introduction. We are really honored to be here. I'm Dr. Dani Dumitriu. I'm going to let my colleague from obstetrics and gynecology first give you a little bit of the maternal side, as it starts with the mom. And then I, as a pediatrician, will move on to tell you a little bit about the baby side.
Yeah, so next slide, please, Dani. I want to echo the thanks and the warm welcomes. Thank you so much for having us. And we'll be speaking today about the experience that we had in New York at the height of the pandemic, which really happened around March and April for us. So my name is Cynthia Jamfi-Bannerman. I'm a professor of OBGYN at Columbia and in the Division of Maternal Fetal Medicine. And then my colleague, you can see Dr. Dani Dumitriu. Next slide, please. So in terms of disclosures, Dr. Dumitriu has funding from NIMH and I have funding from NICHD and NHLBI. As well, I have a grant from Hologic to study prematurity, and I am on the Seroprognostics New York Advisory Board with regards to researching preterm birth. All right, next slide, please. So the SARS-CoV-2 virus made its way to New York City in March of 2021, where we had the first case that was confirmed. And this case was of someone who had traveled back and forth between New York and Miami, but also overseas, became ill. And at the time, while we were watching the news about the infection in China, we had very little information about it in the United States. And we had seen some early cases in Seattle. And ultimately, this man became the first person that was diagnosed as positive in New York State. He was transferred to Columbia's hospital for care. And it became very clear in the first week of March that we were going to see a lot of cases. In fact, we started in our department having daily calls about updates related to COVID after this happened. And our calls actually started on March 11, and 2 days later, we had the first pregnant woman diagnosed as positive. We initially approached this as we had approached Ebola and some of the other viruses that were novel to us, and that we were asking for symptoms and travel. So had you traveled to China, did you have any symptoms or fever? And if you had symptoms but hadn't traveled, we still were considering that negative in late February, early March. There were two atypical cases that led to kind of immediate change. One of the hats I wear is that I'm the fellowship director for the Maternal Fetal Medicine Fellowship at Columbia. And so I heard about both of these cases from exposures to my fellows. One was of a patient scheduled for induction of labor, routine induction at 39 weeks in the setting of diabetes. Her induction was essentially uncomplicated. She was asymptomatic and had serial vital signs for over 24 hours, not suggesting any hypoxia. There's really nothing remarkable about her case until she ended up having a cesarean, which looked like it was going to become a complicated cesarean, and so she needed to be intubated. She was intubated easily, but then they couldn't ventilate her. So in the setting of this kind of new virus coming to New York City, they decided to send COVID testing, and she was positive. In the same 24-hour period, there was another woman, again, scheduled for induction. She had hypertensive disease of pregnancy and also diabetes. She had a long induction. On the postpartum floor, she became short of breath. And for those of you who practice obstetrics, you'll know that there are many reasons that a woman with diabetes, preeclampsia, who's recently post-op would be short of breath. Suffice it to say that she was tested and was also found to be positive. Neither of these women met any of the symptom-based criteria that we would have established, nor were they ever febrile. And so immediately we changed our testing protocol such that there was universal testing, because between these two women, we had about 40 exposures to COVID. And if we had continued in this route, we would really have lost a lot of our staff because we just couldn't quarantine everybody. And so these are really remarkable cases. And what you'll see on the top left corner of your screen is the publication that we had from that experience. And so that was actually in the Gray Journal, the first publication from the United States describing pregnant women with COVID. Next slide, please. So that then led to universal testing. And so we initiated that March 22nd. And we tested everybody that came to the labor and delivery unit for the SARS-CoV-2 virus. And in fact, in the first 2-week period, we had 215 women that were delivered. 13.5 of them tested positive for the virus. Next slide, please. And what was interesting in that was when we had initiated universal testing, we found that almost 88% of the women were asymptomatic. So they were considered asymptomatic positives. So some of my colleagues who work with me at Columbia, published these data, and it was very, very remarkable, because I think not only was it interesting in the context of pregnancy, but because this was still kind of early April, we were understanding that maybe a lot of COVID would be asymptomatic. And I think that that was not yet appreciated widely. And it took several months after, I think, this publication for folks to realize how prevalent asymptomatic positive infection actually was. Next slide, please. So certainly you're not meant to read this at all, but the purpose of this slide is to show that as of June, and to put it into context, our paper was finished at the end of April, but as of June, most of the literature that looked at COVID was from China or outside of the country, with very little inside the United States. And in terms of data on newborns, you could see that most were either asymptomatic or had mild disease. But again, there wasn't that much available from the United States. Next slide, please. And again, in the context of what we could do for moms and babies, there were varied recommendations about separating moms and babies. I've highlighted 3 in the box that talked about possible separation because it was really unknown at the time whether breastfeeding would be something that would either be protective or whether it might make the newborn susceptible to infection. The WHO being the only ones that I think at the time encouraged breastfeeding. It's interesting in that we were in New York City. So in the context of New York City, if you've been here, you realize that we're very dense population-wise, and so we're used to small living spaces. And this is also true of our hospitals. So while the recommendation was to separate moms and babies, we made the conscious decision that we just couldn't do that because we didn't have a place to put everybody. And so we co-located moms and babies. We weren't kind of intentionally going against the recommendations, but we did. And we did that because first there was, again, no space, but we also felt that it made sense that breastfeeding would be a good thing. And so we thought that it would be really important to show our outcomes and to demonstrate that what we were doing, at least anecdotally initially, and then supported with data, was safe. Next slide, please. So in our study design, we performed a retrospective cohort study. This was from March 13, which was our first positive woman, to April 24, 2020. In that time, there were 101 newborns born to 100 women who were positive for the virus SARS-CoV-2. The primary outcome was the newborn SARS-CoV-2 results. And we included maternal outcomes as well as newborn outcomes, looking at asymptomatic mild versus severe critical disease as part of our secondary outcomes as well. Next slide, please. And that leads us to the paper that we published and that we're speaking to you about today. So it was published in JAMA, and it was a huge collaboration between obstetrics and pediatrics. And I think just a very fruitful collaboration in terms of both maternal and newborn outcomes. But in this paper, we showed that the risk of transmission in the setting of co-locating moms and babies and in the setting of breastfeeding with breast hygiene and hand hygiene and moms wearing masks, we showed that the rate of transmission in that context was very, very low and negligible. And Dr. Dimitriou will definitely talk to you about those. If you could press the next button, Dr. Dimitriou. There was actually an editorial that was published also by JAMA talking about balancing the risks and was very favorable towards collecting more data and breastfeeding based off of our findings. Next slide, please. So again, I understand that this is difficult to read and I'm very sorry, but we'll highlight a few changes. These are the demographics looking at mom and baby. You can see maternal age. There were some small differences in maternal age between the mild asymptomatic and severe critical. There were more diabetics who were in the severe range. And the gestational age of delivery was a little bit earlier for those who were severe critical. But we were able to look at our demographics between all of our groups, and here we show what they all were, and you can also see them in the publication. Next slide, please.
So I'm happy to take over, if that's okay. primary outcome of the paper, of course, was how would these newborns fare? And so we had universal testing of all the babies born to mothers with known SARS-CoV-2 or even suspected SARS-CoV-2 infections. And as you can see, we had a total of 2 newborns that out of the 101 that tested positive. And as I'll show you in a second, they actually didn't test positive per se, but intermediate, which is considered a low positive rate. So it is considered positive, but it's considered a very low viral load, which means that it is possible that that could also be contamination. So our confidence intervals, 95% confident intervals indicated a transmission of 0.2 to 7%. And our positivity rate for the 101 tests performed on these babies in total was 1.4%. But here's the really important numbers, which are the clinical-based transmission, which we also included in this work. And we were able to do this because many of our newborns follow up within our hospital system. So here what you see is that 0 of the 101 babies during their newborn nursery stay had any clinical signs of SARS-CoV-2 infection, but also we had follow-up at within the first week of life of 55 of these newborns at a special clinic that was developed very rapidly, a COVID-19 follow-up clinic, and none of those babies were sick either. So our clinical-based transmission really was 0. We also, just to demonstrate a little bit of when we tested these babies, had significant data from a variety of different time points. In the beginning of the pandemic, we tested babies very early, within the first 24 hours, both in the well baby nursery as well as babies admitted to the NICU. But we soon moved to a 24 to 48 hour testing because we wanted to also allow the virus to replicate in case there was viral transmission. And what you can see here is these 2 round dots. Those were the 2 indeterminate test results. Both of those were well baby nursery babies. Importantly, NICU babies were not admitted to the NICU for reasons related to COVID, but just our regular admission demographics. We also, because again, many of these infants are followed within our hospital system, have some interesting data from follow-up within our hospital, either at regularly scheduled visits or in these larger diamonds for clinically indicated reasons. And again, all of those were negative. And just to illustrate the point a little bit further, we identified 23 infants that had 1 or several medical visits for non-routine reasons within our hospital system, including 3 which actually came in for fever and were admitted to the hospital for a rule-out sepsis. And 6 of those infants were retested for SARS-CoV-2 and tested negative. In terms of the demographics, again, looking at differences perhaps between babies born to mildly symptomatic or asymptomatic mothers versus severely or critically ill mothers. Just to reiterate, the one difference was the gestational age, which was slightly shifted towards about a week younger. And the only other difference we identified was an interesting difference in the rate of phototherapy required. And we weren't completely sure what this was driven by, but perhaps we might have some indication by looking at the differences in our well baby nursery infants versus NICU infants. What you can see here, out of the total of 101 infants, we had 82 that were admitted to the well baby nursery and 19 that were admitted to the NICU. We are at the tertiary referral hospital, and that rate of about 20% NICU admission is actually quite common for our hospital. One interesting feature here is that the gestational age difference, that 1 week difference of being born earlier, is really not driven by the severely premature. There has been some there had been at the time some indication in the literature of severely premature infants being more commonly born to mothers with SARS-CoV-2, especially mothers severely critically ill. But we actually saw a pretty similar 1-week shift across the board in terms of being born earlier. Also, the difference in terms of phototherapy was entirely driven by the well baby nursery population, which is pointing more towards changes in our clinical practice, of which there were numerous, including babies being sent home or moms and babies being sent home on average about a day earlier, with vaginal deliveries going home at around 24 hours and cesarean deliveries going home at around 48 hours. So, for example, one of our practices was to err on the side of caution and initiate phototherapy at slightly lower thresholds. We haven't quantified that, but that's sort of my experience in the nursery. So, as Dr. Giampi-Bannerman mentioned, the most important concept here is how we achieve these rates. As we showed you earlier in our systematic review of the literature, the infant rate of positivity was around 4.5%. We had 2% and also much lower rates in terms, and 0% in terms of clinically ill babies. And importantly, unlike many of those infants in the literature that we had reviewed, all of our well baby nursery infants, almost all, roomed in with their mothers, unless there was a medical indication either for the mom or the baby to not be together. So, for example, there were some moms that were critically ill, either with COVID or for other reasons. So all of the well baby nursery babies roomed in. We not only allowed direct breastfeeding, but actually highly encouraged it. Both myself and my colleagues in the nursery spent a lot of time with moms, encouraging them to breastfeed. We did, of course, follow precautions. All moms wore masks the entire duration while in the hospital, with the exception of when the infant was in an isolate 6 feet away from the mom. And that was, of course, in order to allow her to eat, for example. When moms would breastfeed, we went over hand and breast hygiene with soapy water, and this was required every time they would touch the infant. And also, one of the recommendations early on from multiple organizations had been early bathing, which we did not feel had any evidence-based reason to be done. And so we actually, after about a week or so, stopped the early bathing practices. And this was because, as many of you might know, early bathing can interfere with numerous processes, including breastfeeding, but also can lead to hypothermia and hypoglycemia, which we did not want to happen. So the conclusion based on empiric data, and again, I want to emphasize, as Dr. Giampi-Bannerman did, that this data was actually submitted on April 27. So we very rapidly mobilized and put together this data and submitted it because we felt that this was really important for evidence-based practice. And our conclusions were that rooming in is safe if mom wears a mask and practices appropriate hygiene, that direct breastfeeding is safe and perhaps even protective. While at the time we did not have that that type of evidence, there is certainly evidence now from other groups to indicate that breastfeeding might be protective, and that early bathing was not necessary and may in fact be harmful. So great, low risk of vertical transmission. That means that we are all day done. We can call it a day, right? Well, not really. We do know from other viruses that in utero viral exposures are associated with adverse neurodevelopmental outcomes. So for example, it took a long time to realize, but non-HIV positive babies exposed in utero. So babies that do not develop, do not have vertical transmission of HIV but are exposed in utero have, for example, slight motor delays and in some cases slight language delays. We also know that prenatal stress is can negatively impact both mom and baby long-term health. This has been studied in numerous animal models as well as is very well established in the human literature. There's also numerous changes in medical practice that might have affected both the physical and mental health of both mom and potentially baby as well. We know, for example, that children are much less likely to go to their regularly scheduled visits at the height of the pandemic. And there's numerous other mechanisms by which there could be changes. So, for example, the pathognomonic loss of smell could potentially affect mother-baby bonding. The odor of the baby is pleasant things to a mother, and it is very important in establishing that connection between mom and baby. So in order to study these numerous potential outcomes, we developed the COVID-19 mother-baby outcome study. It was a rapid mobilization of a very, very large team. There's roughly 100 physicians and scientists involved in this effort. It's a combo cohort that we plan on following up long-term. It's highly multidisciplinary, and we've really used a collaborative approach to look at a broad number of outcomes with each member participating in terms of providing the most expertise, their particular expertise. So, for example, we have members from endocrinology, we have members from both child and adult neurology. We have members from pulmonology, and we really are interested in understanding and understanding how this disease might affect long-term outcomes in infants sooner than some of the effects we learned from, for example, the HIV epidemic. It took a very long time for us to realize some of these very subtle effects, and we, with this combo cohort, are hoping that we will rapidly generate knowledge. So to give you a little bit of a timeline, as well as our hospital center has roughly 6,000 births per year. An interesting historical fact is that on February 1st of this year, the Epic Medical Record EMR was introduced, and that has actually allowed us to both take care of our patients a lot easier during the pandemic, but also to gather information a lot easier. On March 13 was the first woman with positive for SARS-CoV-2. As Dr. Gianfi-Bannerman mentioned, on March 22nd was when universal testing for SARS-CoV-2 for all mothers admitted on labor and delivery began. And on July 20th, we also introduced universal testing for antibody. And so this has really allowed us to identify some of these exposures that might have happened earlier in pregnancy. And another interesting historical fact that I want to introduce to you is that New York had a pretty interesting experience in terms of the pandemic. We were the first and largest epicenter, but we had a very rapid on and then off phase. And so while there is now a resurgence, I also want to point out that this very large peak is primarily due to increased testing. So if we look at, for example, hospitalizations, you can see that we had a very, very low rate in the summer and early fall, and we're just entering this new peak in New York. So why is that important? Well, we described today findings of women who had SARS-CoV-2 infections perinatally. So either at delivery or late in third trimester. But of course, women over New York who were pregnant at various stages during the peak of that pandemic. And so what this allowed is a really interesting natural experiment with most of the babies born in spring having exposures in the third trimester, babies born in the summer. If mom was identified to have had COVID either by PCR or by an antibody test, were likely exposed in the second trimester, and those born in the fall exposed in the first trimester. And indeed, we are just now starting to have this overlap. So we've gone back over the records, and we can, for many of the women, about 90% identify down to the week, the exposure, the in utero exposure. And we indeed have a number of exposures in the second and third and first trimester. So we actually hypothesized very early on that we would have a steady rate of babies born with in utero exposure. And indeed, based on records, since then, we have continued to see approximately 15% of our births with evidence of mom having had SARS-CoV-2 at some point during her pregnancy. And that 15% rate, as you might recall, is very similar to that rate of the 13.5% on universal testing the first 2 weeks. And so that's actually stayed quite stable. So for combo, there are several layers. The first overarching layer is a chart review of all infants born between February and through the end of this year. And initially we had through the end of December as our end date for enrollment, but really now that we are entering a second peak, we do not wish to stop enrolling. That includes roughly 5,500 dyads, and roughly 800 of them have evidence of in utero exposure. So to give you just some very preliminary data, and also all of the data that I will be showing you from now on is unpublished. And so hopefully stay tuned. We will have a website. Also, we are dedicated to preprinting in the future so that we can rapidly disseminate our information. So please stay tuned for the combo website and also for medRxiv preprints. We are preparing a follow-up report on vertical transmission. We looked at all babies born between March 13 and August 7. And the reason we chose August 7 is because those babies were universally tested. So even if mom was only positive by antibody, we universally tested all babies with any maternal evidence of SARS-CoV-2 through August 7. After August 7, because of the very low rate of positivity, we could continue to test babies if mom is perinatally infected. And out of those 330 babies, so that includes the 101 that we talked about in the beginning, 3 total have tested positive. So there were the 2 that we already described, and then a third one. And interestingly, that third one might have actually been a false positive. It was a positive result. We immediately repeated it about 4 hours later, and that came back negative. And we thereafter tested the baby 2 or 3 more times within the first week of life, and all tests were negative, including on follow-up. But overall, our positivity rate is 0.9%. So that includes exposures in third trimester, as well as a significant proportion of these 330 babies were exposed in the second trimester. And of course, most important, the clinical sign of COVID-19 in terms of clinical transmission, we have had 0 babies. And that is a manuscript in preparation. We are also working on the epidemiology on infant COVID-19 disease within our hospital system, as well as some very interesting findings on fetal growth, which are in preparation as well. The second layer of combo is an in-depth look using surveys at numerous outcomes. And for this, we enroll both prenatally. There's a prenatal enrollment arm in which the SARS-CoV-2 status is generally unknown at the time of enrollment, as well as a postnatal enrollment arm in which we target all the moms that give birth within our hospital system with known SARS-CoV-2 infections during pregnancy. All moms are invited to participate, and we've enrolled through the age of 6 months. Our goal has been from the beginning at least 600 dyads. We are almost there. And again, because we are seeing this new resurgence in terms of the SARS-CoV-2 infection rate in New York City, we will continue to enroll. One really interesting feature and possibly unique to our cohort is that we decided to case match not based on maternal demographics, but rather on newborn demographics. And the reason for this was to really develop a cohort with ecological validity such that we could see how this pandemic is actually affecting certain populations. And as you can see in the first 279 enrolled dyads, postnatally enrolled dyads, in terms of, for example, the Hispanic population, the COVID positive moms are 64% identifying themselves as Hispanic versus 45% in the COVID negative case matched moms, which is 45% is actually very much in line with our overall demographics within our hospital system. This is, of course, statistically significant, but also quite interesting, and we really feel that this will enhance the validity of our study, because if we identify differences, we can also look at the perhaps intricate ways in which things like socioeconomic status and race and ethnicity might actually contribute to some of these outcomes. So total, this is data from through a few weeks ago. We've enrolled 530 dyads, 180 of them prenatally and 350 postnatally. We have roughly a third of moms that we approach postnatally enroll with us, which is relatively low. However, actually it's higher numbers than what we've seen from other studies. It's been really tough to enroll during COVID because many of these moms are approached by numerous individuals for enrollment. And so we do have some preliminary data to share with you today, which is, again, unpublished. It is being put together, spearheaded by Dr. Walzer, one of my Well Baby Nursery colleagues, on breastfeeding rates. So this is data from moms who responded to our surveys, and also we were able for those moms to go back into the hospital record to also look at whether or not they breastfed while they were in the hospital. Of course, we have much lower numbers for the 4-month group because many of our babies haven't quite aged into 4 months yet, and we have about double the amount of data for 1 month. And also we need to really start delving into this data a little bit more in depth to look at time effects, because certainly at the height of the pandemic, things were a lot different than now. But as you can see, for the most part, there was no difference in terms of breastfeeding in the hospital for these moms. It is trending to be a little bit lower for moms that had SARS-CoV-2 at any point in pregnancy. And just to emphasize, the exposed group contains moms and babies with exposure at any point in pregnancy. So even if the exposure happened in first trimester, they're considered in the exposed group in this graph. There's no difference at 1 month, no difference at 2 months, but starting to trend. with the exposed group having less breastfeeding. And then we do see a significant and very interesting drop in breastfeeding at 4 months that is significant for the exposed group. When we asked these moms why they stopped breastfeeding, there was no difference in breastfeeding demands, in supply or pain. But interestingly, the exposed group did report more difficulties with the latch, as well as more concerns about COVID. So another layer of combo is that we really want to understand some things in much more depth in smaller numbers. So we are conducting a number of sub-studies within combo that involve video visits. There's some fMRI that will start soon. There's also, for example, this QMR here that is a very interesting body composition measurement that our endocrinology team is spearheading. And so today I'll just show you data from an ongoing video assessment at 4 months. This is a very innovative study using Zoom video visits with moms and babies to really hone in on the mother-infant relational health, which, as you probably most people on this call recognize, is a really essential component of development. So we have the 3 main assessments of this video visit, which is about 45 minutes or so, is a face-to-face free play on mom's lap, where we just observe mom and baby interacting with each other, a maternal caregiving paradigm, as well as a novel mask face paradigm that we developed, which is basically an adaptation of the still face paradigm, but instead of a still face, mom is wearing a mask and continues to interact with the baby. I will not show you data from the mask face, although we do have some very interesting data already. But to just show you the study so far, we've had 57 of these videos completed. We do also have a group of babies born in February, which we're calling stress control group, as well as we've completed now 23 videos with from the COVID positive group and 23 from the COVID negative group. And so I'm going to show you some preliminary data that is obtained from the Nurture Science program. One of my many hats is I'm the Director of Translational Research at the Nurture Science program. And the Nurture Science program, which was founded and continues to be directed by Dr. Martha Welsh, my good friend and collaborator, has developed a very brief validated behavioral screen for mother-child emotional connection called the WEX. This is a really important tool because it allows a trained observer to actually code for the interaction between the dyad within a very brief assessment of just 2 to 3 minutes is actually all it takes. It does take a few months to train, but once you have a trained observer, this is a very, very quick scale. It importantly has been shown already to correlate with infant physiology. It has been shown already to have predictive validity for long-term outcomes. So some of the data from the Nurture Science program shows that the WEX at 4 months is predictive of several outcomes at 14 months, including risk of autism, behavioral problems, and even cognition with 75 to 88% sensitivity. The WEX measures 4 behavioral domains. These are attraction, so how attracted is mom and baby to each other, vocal communication, facial communication, and sensitivity reciprocity. And these 4 subscales actually sort of come together to give one final score of emotional connection, yes or no, which is not really based on a cutoff, but rather the overall impression of how the dyad interacts. And so spearheaded by Dr. Amy Hain, a professor of psychology at Williams College, who also serves as the director for behavioral coding at the NutriScience program. This scale was validated against much more time-consuming measures that involve very detailed coding of maternal and infant behavior. And also importantly, we have some normative data from our hospital. So in a prior clinical trial that Dr. Welsh completed within the NICU population at our hospital, we have some data in terms of what the percentage of emotional connection is. And importantly, this is, in some sense, also a stress population, because as we know, the NICU population has numerous stressors for both moms and babies. And so in that prior study, 36% of moms and babies that were observed using the WEX were coded as being emotionally connected in the standard of care. So these are just normal NICU infants and moms. But with an intervention, family nurture intervention developed by Dr. Welsh, 58% of the infants were emotionally connected. And so in our study, we have some preliminary data. And what we see prior to the pandemic, so babies born in February, again, as a stress control group, of course, as a stress control for the birth, but these babies have, of course, undergone a stressor during their first few months of life. But in that population, and again, this is very preliminary, the sample size here is only 10, 40% of those infants, moms and infants, were emotionally connected. This is all blinded in terms of coding, and been coded now by 2 coders. Whereas in both the unexposed and exposed group, we see roughly half of that in terms of emotional connection. Really low numbers. It does not seem to be mediated through infection. It's most likely mediated through the stressor of the pandemic and giving birth during the pandemic, as well as potentially numerous other mechanisms. And when we look at the subscales that I mentioned, the WEX codes for attraction, vocal communication, facial communication, and sensitivity, reciprocity, all of them are affected, although it's interesting and actually already significant that the attraction seems to be the most affected. And so in part because of this, and in part because we already suspected this and hypothesized we would see this effect on moms and babies, we have also initiated a clinical trial of family nurture intervention. We started it in the summer, and we're not really aiming to capture particular rates of COVID positive versus COVID negative, but really trying to help these moms and babies emotionally connect during these very trying times. So the final slide that I will show you is not really meant to be read, but rather to just understand just how many outcomes we are evaluating. Again, it's a very large team. We have entry points from the prenatal time through 6 months. We also, at the time of delivery, for those enrolled prenatally, have started collecting biospecimens, including placenta and cord blood and maternal blood. We are also conducting our olfactory testing in the nursery to see if perhaps that might mediate some of these bonding impairments that we're seeing. We have surveys at key developmental stages. We have the 4-month video that I just described to you, another 9-month video about to start, which is really focused on both neurodevelopment of the baby, but also cognition of moms, because we are seeing in the literature some persistent effects of COVID-19, and anecdotally, we are definitely seeing that also as clinicians. We are also about to start fMRI of both mom and baby brain. And of course, we've only been planning out the first 12 months, but we really are interested in long-term follow-up of these infants and their moms. So with that, I'd like to thank numerous people. In fact, there's so many, they really don't fit on the slide. I'll give a special shout out to Maggie Kyle. She is the research coordinator for the entire combo, and we really work side by side, day and night, really, since the pandemic started, and really none of this could be done without her. But again, it's a very large team. So here's just some of the folks involved in the surveys, as well as some of the folks involved in the video visits. Thank you very much, and we're happy to take questions.
Thank you, Cynthia, I'm sorry, and Danny, for that information. It was very interesting, to say the least. We do have about 10 minutes for questions. So feel free to submit them into the chat function, and we'll try to get to the ones that we have come in. We don't have any as of yet. We did have a few people asking about handouts for this, and if either of you want to speak to the reason of why we didn't provide handouts, you can do that.
I'm sorry, what type of handouts? Is that a question for us?
Correct. We were asked by several people why we weren't providing handouts for this webinar. And my guess is because the research has not been published yet.
Oh, yes. Yeah.
And it's still ongoing.
Yes. Most of what we showed you today, so the first half of the talk is already published, of course, and we're happy to, if you email us, to provide you with a copy of the published JAMA Pediatrics paper. But really everything in terms of combo is as of yet unpublished. Again, please stay tuned. If you Google combo and Columbia in the next few weeks, we will have our website up and running, and we will put all of the new research up on that.
Okay. There's a question that came in. Were clear masks considered to improve the emotional connections?
That is such an excellent question, and absolutely. We've considered clear masks a lot. At the time that the pandemic started, there really wasn't any option. There is one now, FDA approved, and indeed we had approval from the hospital to use those masks when we bring in these babies for follow-up. We initially had planned to bring in these babies at 6 months in order to do an, but that was right around the time that the new surge in COVID-19 began in New York City, and we made the decision that that was not really safe. But we would have used the clear masks in that case.
Yeah, we actually also thought about using it for our research staff because they felt like they couldn't kind of interact with the patients in the way that they would have if they didn't have to wear masks. So we did look into clear masks as well in that context.
Okay. The next question is, what do you attribute to the difficulty some COVID positive mothers had latch?
I didn't catch the last word.
Latch?
The latch. So we don't know. It's a really interesting question. But one of the things that did happen was that breastfeeding support in general was a little bit impaired. We in general have understaffing in terms of breastfeeding support, and with having numerous contact rooms, it was very hard to reach everybody during the height of the pandemic. So that could have definitely contributed to it. I think also once moms left the hospital, there was likely less breastfeeding support also in the community. again, babies in general weren't going to their healthcare provider visits as much as normally, and so that could have also contributed.
Okay. The next question is, was the low score on the WEC scale a surprise given that you didn't separate moms and babies?
Well, it really wasn't a surprise because even though we did not separate moms and babies, there are numerous things that could impair that bond. Stress is very well known to do that, and I can tell you that at the height of the pandemic, these moms were very stressed. I don't know, Cynthia, if you want to also comment a little bit on from the maternal side, but there's lots of reasons why there could be impairment.
Yeah, I would agree. The stress level here was, I think, through the roof, and we had changed visitation policies also early on, and so I think it was quite the struggle for new moms, whether first time or moms who have many children, to be able to do the same types of things in the hospital that we usually would expect. We had actually also engaged research staff to be able to help facilitate kind of a virtual experience for the rest of the family since they couldn't come to the hospital. But I think there were so many variables in place that were acting adversely towards all of the bonding and the breastfeeding.
Okay. The next question is, can you elaborate on what could be the hypotheses for the drop in breastfeeding at the 4-month time point in the COVID cohort?
So I can't yet. We are running a lot of models right now. It could be mediated through the differences in the socioeconomic status and the race ethnicity that I showed you we have between those two groups. It could be mediated through the bonding, for example. You can imagine that a less emotionally connected dyad has a lower chance of continuing to breastfeed for a prolonged time. There could also be external stressors that are higher for those moms. There are so many mechanisms by which this could happen. We are investigating some of them in our mediation moderation models right now, and I don't really have the data for you yet. But there's also likely going to be additional ones that we will have to continue to look for.
Okay. Looks like we have time for maybe one more question. The next question is, are you looking at growth rates in infants in the exposed, unexposed groups post-birth? If so, what are you seeing?
Yes, we are. I will have to let you wait for just a little bit longer. We are definitely seeing some very interesting trends, but again, it's too early in the analysis, and I don't want to accidentally give you something that might not be correct as of yet. I can tell you that we've just started these much more interesting assessments. So this QMR, which is quantitative magnetic resonance, is basically like an MRI, but very, very low Tesla, and that evaluates body composition. So our endocrinology team, spearhead by Dr. Eileen Benoit and Sharon Oberfield, it has just started. Actually, the first baby was put into the QMR machine this past Monday to really start to get very accurate measurements rather than just the chart review data that we can get right now. So stay tuned for that.
Okay, thank you very much for that. Looks like we're almost at the top of the hour. Just a couple quick things before I hand it back over to Nania to close this webinar. For the U.S. attendees, your certificates will be available this Friday by logging into your account. And registration is now available and open for our December 16th webinar, as well as the January 20th webinar. Nani, if you have any closing thoughts, go right ahead.
I just wanted to thank you both. It's been super interesting, worrying to a point as well, but I think it's good to know what's happening, to see how this can be tackled, and make sure that that this generation that is coming now through this COVID times is not affected in dramatic ways. So again, thank you very much for a super interesting presentation, and all the best for the holidays.
Thank you. Thank you very much for having us.
Thanks.
Thank you.
Bye, everyone.
Bye.